Hi everybody, welcome back. Today's video we're going to talk about the physiology of bladder function. We all take for granted that our bladders work, more or less, some better than others. But did you ever wonder how they work? That is to say, how does your bladder empty when you want it to empty? And why doesn't your bladder just empty all the time? Well, today we're going to talk about these things. This is actually a talk I'm getting ready to give in a couple of days in Salt Lake City at the Functional Aging Institute Summit. And I thought it'd be good to go ahead and turn this into a YouTube video for all our subscribers and visitors so that the people attending the lecture can make reference to it, because, you know, it gets a little bit thick towards the middle and maybe worthy of review. So, welcome to everybody. Today we're going to talk about PfilAtes, how it works, why it works from a neurophysiology standpoint. You know, my name is Dr. Bruce Crawford. I'm a board-certified urogynecologist. And back in 2004, I think it was, I started going to West Africa to do these surgical missions to repair something called an obstetrical fistula. That's a maternal birth injury that occurs in sub-Saharan Africa. Really occurs anywhere that doesn't have access to emergency cesarean section. So all the resource-challenged parts of the world. And in sub-Saharan Africa, there's like 2.5 million women living with something called an obstetrical fistula. And that's a maternal birth injury that occurs as a consequence of obstructed labor, whereby the baby's head puts so much pressure on the top wall of the vagina and the back wall of the bladder that ultimately the top wall of the vagina and the back wall of the bladder dies because of that constant pressure and sloughs, leaving a hole between the bladder and the vagina. The consequence of this is that these young women are completely incontinent of every drop of urine their body produces. It is hard enough being a woman in Niger without having a obstetrical fistula. And so we would go and fix 200 or 300 fistula a year, and pretty successfully. And after doing this for a few years, it became apparent that not all of the successful repairs had actually restored continence, that is to say, bladder control. And in fact, as many as 50% of these women still remained incontinent of urine, not through the fistula, that had been repaired, but through the urethra. And it really opened my eyes to the fact that the mechanisms of bladder control that had been instilled in me, and I think many other gynecologists and urogynecologists through our training, the idea that bladder function or bladder control is a mechanical phenomenon. I was really challenged by this because as surgeons, we like to believe if you restore structure, you'll restore function. But we really weren't seeing that in these patients with fistula. We had restored structure, but function, that is to say, bladder control, eluded us. And the reason for that, I came to realize, was that bladder control is a neuromuscular phenomenon, right? It's a performance phenomenon. It is, in other words, a fitness issue. And we really hadn't been developing and prescribing fitness solutions adequately, right? We had been too quickly going to medication and surgery as treatment options. You know, it's common to say go home and do your Kegel exercises, basically recommending a form of home physiotherapy that was state-of-the-art in 1948 when Arnold Kegel wrote his famous paper about pelvic floor exercise and why women at least should do it. Men and women should do it, of course. But it needed an update. And so I set out to do that. And spent a lot of time pursuing an understanding of the way movement affects the pelvic floor, believing that if we had a program of movement, it would be more practicable than Kegel exercises, something that could be incorporated into a regular fitness routine. And to study the effect of movement on the pelvic floor, we had to figure out a way of monitoring pelvic floor activity during movement, which didn't exist. And so we had to invent something. And That something is called video EMG synchronization. It's a way of monitoring the pelvic floor, but also other muscles of movement related to the pelvic floor, like the abdominal muscles and the butt muscles and the inner thigh muscles, at the same time as we record video, and synchronizing it together so we could determine, after studying a whole bunch of different fitness and yoga and Pilates movements, which ones actually passively, automatically engage the pelvic floor. And from this data, we extracted 10 movements we thought were reasonable for the public at large, and that became the PfilAtes method. Now, we don't recommend today that people do all 10 movements. We recommend you find your best 2 movements. And people that take our online P49 course through PfilAtes.com are instructed in just that way, and we give them help and guidance and a movement selection worksheet so they can find which 2 movements are their best movements, and then they just practice those 5 minutes in the morning, 5 minutes in the evening with excellent results. So, that is the background of my experience that led to the development of the PfilAtes program. But I want to talk to you a little bit more about the backstory. How does PfilAtes work? We know that it works, but if we understand how it works so efficiently, so effectively, I think, hopefully, you will be more motivated to give it a try and to tell people about it. Speaking of which, if you share this video, that helps tell people about it. If you like and subscribe, that helps us also. So thanks for doing that in advance. Right, so let's look at some pictures together. The first thing, and the most important thing, I want to emphasize is learning how to pulse. If you're doing the PfilAtes movement, the power is in the pulse. What makes you better is your effective pulsing technique, and it takes a little bit of practice, but once you get the hang of it, it's no big deal, no big deal. The 3 essential elements of pulsing, if you only remember one thing from this video, remember these 3 things. Number 1, small range of motion. Number 2, percussive breathing, and number 3, voluntary pelvic floor contraction. Those are the 3 essential elements of pulsing. You see, this is the access point to the autonomic nervous system. So if you have overactive bladder, this is how PfilAtes is going to make that better. Also, the pulsing technique works on the pelvic floor muscles itself to make those fast twitch fibers bigger and stronger, and also to make the fast twitch fibers all contract at the same time, so you're increasing both strength and speed. That's power. So pulsing is the essential element. Everything else is just getting you ready to pulse. You see, these movements have been designed to get the pelvic floor to contract whether you want it to or not, automatically. Not to an extreme degree, but it gets the pelvic floor to contract maybe 50% of its maximum contraction potential. We call that preloading. And when you start pulsing the pelvic floor from a preloaded state, you get all kinds of excellent benefits, and we're going to talk about what those are. Now, there is a ton of literature talking about the relevance of this topic for older adults. And this is just one sample that talks about how urinary incontinence increases the risk of hospitalization and nursing home admission. I don't think there is another fitness issue that is more significant than pelvic floor performance in terms of preserving dignity and independence. And so take this to heart. What we're doing here is a fitness solution to a massive public health problem. And it's better to start this before you're experiencing the degradation in quality of life that comes along with worsening incontinence, whether it's bladder control or bowel control. Start now. It's worth the investments. It's only a few minutes, a couple times a day, no big deal. Now, we're looking at this picture of the pelvis from the side, and you can see that the pelvis is actually made up of 3 different bones. And what's important about this picture is it illustrates the point of origin for 3 muscle groups that are naturally neurologically related to pelvic floor activity. And so up here on this portion of the pelvis, which is called the ilium, there's this top edge called the iliac crest. And a deep abdominal muscle called the transversus abdominis arises from the iliac crest here, and it extends all the way up to the sternum. And down here, along the lower portion of the pubic bone and this portion of a bone called the ischium, the inner thigh muscles arise. They're called the lower extremity adductors, and they travel all the way down to the bottom of the femur, right, basically at the knee, and you use those muscles to bring your legs together in the midline. And then finally, you see this hollowed out space here in the ilium, the iliac fossa, as it's called? Well, that's where your butt muscles arise from, the gluteal muscles, and they travel down to the top of the femur, and you use those to move your leg backwards. We say hip extension. Now, neurologically, all those muscles are related to the pelvic floor. When those muscles contract, one or more, the pelvic floor also tends to contract. Now, it's not the same in every individual. Some people get more pelvic floor activity from their glutes. In fact, that is probably the most dominant of the co-contractors of the pelvic floor. But there are some people that get more activity from the transversus abdominis or from the inner thigh muscles. And you'll figure out which one of those people you are as you go through the 10 PfilAtes movements and evaluate them, score them, and then use that score to help you pick the movements that are right for you. Now, on this slide, we're looking at the pelvis from below. We say an inferior aspect. And you can see the pelvic floor muscles arising from the pubic bone up here, descending by the genital structures and around the anal canal and back up the other side as if a sling. And there's actually 3 different pelvic floor muscles. There's the pubococcygeus, and that's the one closest to the midline, the one we're most concerned with. It does most of the heavy lifting of the pelvis, if you will. But there's also these other flatter, broader pelvic floor muscles, the iliococcygeus and the coccygeus. We don't need to worry too much about those. We're really interested in training the pubococcygeus and optimizing its performance for both the effect on stress incontinence, overactive bladder, but also sexual response, bowel control, and a prevention of pelvic organ prolapse. Believe it or not, that's one of the jobs the pelvic floor has. Now, traditionally, when you go see a physical therapist, what they try and get you to do is isolate the pelvic floor muscles. And if you make the mistake of trying to use one of these other muscle groups that we've been talking about, you might be stopped and corrected and say, no, you're not doing it right. You must isolate the pelvic floor muscles. And it's extremely challenging and maybe frustrating even to try and do that because it is not natural to do that. You see, these muscles naturally work together with the pelvic floor, the floor of the core, if you will. And if you understand that, you can leverage it and make a more effective pelvic floor training method. That's what PfilAtes is. Now, look at this crazy looking slide demonstrating my incredible graphics skills. This slide shows us a couple different things. One, it depicts basically in schematic form how our nervous system is set up. You see, you have the central nervous system consisting of the brain and the spinal cord, and you have the peripheral nervous system. Now, the peripheral nervous system is divided into 2 parts, a somatic portion and an autonomic portion. The somatic portion is the portion that serves your skeletal muscle and your skin. We tend to have voluntary control over somatic nerves. And then on the autonomic side, that portion of the peripheral nervous system brings nerve supply to the internal organs, and it is responsible for our heart rate and blood pressure and our gut activity, and also bladder control, to the extent that we can void at a normal schedule and not have that scary urgency experience that makes us feel like we need to rush to the bathroom, right? That's all a function of autonomic control. The fact of the matter is, though, the nerves that go from the spinal cord to the skeletal muscle are actually 2-way streets. The line you see, the arrow you see pointing from the spinal cord down to the skeletal muscle is an efferent pathway. This one here, going from the spinal cord down to the muscle, it's bringing a motor signal telling the muscle to contract. But in the other lane is an afferent signal, that is to say a sensory signal going from the muscle back up to the spinal cord and then back up to the brain. Now, perhaps at the level of the spinal cord, but for sure within the midbrain, are communications between these somatic nerves and the autonomic nerves. So every time a skeletal muscle contracts, it contracts because the motor nerve from the central nervous system got to the muscle, said time to contract. And when that happens, it creates a sensory signal or afferent signal that goes from the muscle back to the spinal cord and the brain. And it has an impact on the autonomic nerves, in this case, for our purposes, to the bladder. And that's how pelvic floor exercise actually improves something like overactive bladder, because the somatic sensory response to a muscle contracting tends to cause the bladder to be less sensitive and to not contract when you don't want it to. And that is the backstory behind why doctors have been telling people to do Kegel exercises forever and ever and ever, right? And so that's what you need to know. Now, here's another way of looking at the same thing. On the left side of the screen, we see the bladder and the urethra here, and this represents, for our purposes, the pelvic floor. And so when the pelvic floor contracts, here's that sensory signal depicted as this line going back on over to the spinal cord. It actually enters the spinal cord from the same nerve roots that the pudendal nerve comes from. The pudendal nerve is the somatic nerve that brought the motor signal down to the pelvic floor in the first place. And so the sensory signal goes right back up the other lane of that same nerve and goes to the spinal cord. And then it possibly interacts with autonomic nerves at that same spinal cord level, because the parasympathetic nerves to the bladder, the autonomic nerves that make the bladder contract, come from the same spinal cord level as the pudendal nerve, S2, 3, and 4. I think that's likely the case, that it occurs at the level of the spinal cord, but the evidence is even stronger that there is or an interaction between the somatic side and the autonomic side that takes place at the level of the brainstem and midbrain. You see, there are structures that are critical for bladder control within the central nervous system, within the brainstem and midbrain, called the pontine micturition center and the periaqueductal gray matter, that absolutely are influenced by ascending afferent somatic signals. And that's the way technology like neuromodulation works. Maybe you've heard of something called InterStim, and there's some other products on the market now that kind of do the same thing, where an electrode is implanted near one of the sacral somatic nerves, and it is then stimulated with a little battery pack, kind of like a pacemaker that gets implanted in the fat of the buttock. And that stimulation creates an ascending afferent somatic signal, and it probably interacts at the level of the spinal cord, but it for sure sends all the way up into the brain and then interacts either at the brainstem or midbrain levels, and improves bladder function in that way. And so there's a lot more to the way neuromodulation works, but suffice to say that maybe you figured this out already. Pelvic floor exercise, the rationale or the way we explain why does pelvic floor exercise actually improve something like overactive bladder, an autonomic abnormality. Why does pelvic floor somatic exercise improve this disorder? Well, we would suggest that it is the same kind of mechanism. It's the same kind of mechanism, generating an ascending afferent somatic signal that has a favorable modulatory regulating effect on the autonomic side. Isn't that cool? Isn't that cool to understand? So every time you're doing your PfilAtes exercises or any other pelvic floor exercise, know that the benefit you're getting in terms of overactive bladder at least, but also probably to some degree, stress incontinence, sexual response, bowel control, is because of this really cool interaction, this way of treating an autonomic abnormality with a somatic solution, right? That sounds pretty hopeful, doesn't it? Hopefully it gives you hope that there is a means to the end with this frustrating quality of life issue. Now, what you're looking at here is a Vessi clip, video EMG synchronization. That's that thing I'd invent to study the effect of movement on the pelvic floor. And what we're going to look at is how this client, who's being coached by this excellent instructor, performs in terms of pelvic floor response when she does a modified bridge movement, one of the 10 Pilates movements. And so on the top line here, we have the EMG signal from the pelvic floor. She's wearing little surface EMG sensors under her clothes. And we're also monitoring her gluteal muscles, and I bet you can guess the other two, right? The abdominal muscles and the inner thigh muscles, all four at the same time. And you probably won't be shocked when I tell you the idea is to get them all working together because the co-contractors facilitate greater pelvic floor activity. So if we can get the pelvic floor preloaded, partially engaged, before the pulse comes along, and that's this last sort of picket fence looking area here, if we can get it preloaded and then pulse the movement, we can optimize its performance, and doing so helps people get better quickly, which is essential because they'll quit if they don't get response within a reasonable amount of time. And so we always start the experiment with a so-called isolated Kegel. We ask the client, without doing any movement, just go ahead and contract your pelvic floor. And what's interesting is she can't do it either, right? Look, when she's asked to do her best Kegel exercise, she's using her abdominal muscles, she's using her glutes, and that's because that's the way she and every other human being is naturally wired, right? So I'm going to go ahead and play this, and you're going to see this little line moving across the screen here. That corresponds to where she is in the movement. And so she did her isolated Kegel, so-called, and now the ball's between her knees to give her a little bit more inner thigh activity. And you can see the tremendous response just holding the ball has. Now she's going to do 3 repetitions. She's going to do 3 simple repetitions of this partial bridge, and you can tell she's already getting more pelvic floor activity than her Kegel provided, right? And she's going to come up and she's going to hold the movement. This is the second portion of each Pilates movement. We call it the hold, peak passive engagement of the pelvic floor. And now she's going to pulse. She's making a small range of motion. She's breathing in this thing with this technique called percussive breathing, and she's adding a voluntary Kegel exercise. She's getting all 4 muscle groups to work together the way they were meant to. And if you actually measure how strong those pulse contractions of the pelvic floor are, they're 300% better than her simple Kegel exercise. So hopefully that convinces you well that this is a better way of doing pelvic floor exercise. Now, here's another little experiment we did that shows the Pilates movements can be interpreted as functional movements. You see, the person on the right here is wearing the sensors under her clothing. They're a little bit awkward, that's why she's walking kind of funny. And we're going to look for some stairs. And this was done a few years ago. I think we were in Phoenix when we did this. Anyways, we find some stairs, and we're going to ask her, okay, now go ahead and climb the stairs. You can see this is where she is in the video. And she's going to climb them just the way she normally would, just climbing the stairs, not even thinking about moving from her core or anything like that. And she's going to turn around on the landing. That's where the pelvic floor rests, right here when she's turning around, and then she comes back down. Now, we say, remember what you just learned about the Pilates lunge. We want you to go ahead and climb these stairs again and move from your core. Just make a little conscious effort to engage the core as you do this mundane movement of everyday life, right? And you can see how much more pelvic floor effect she's able to get from doing this. And this is another example that shows the second Pilates movement. Lunge is the first, the second one is squat. And what you're seeing here is I'm kind of blocking it with myself here. Let me move that a little bit. You can see her sitting down in a chair, and standing up again just the way we do a million billion times every day without even thinking about it. We just throw ourselves around without even thinking about it. But in fact, if we're conscious of how we move and make a tiny effort to move in this PfilAtes technique, moving from the core, you can have a big impact on your pelvic floor, which we think matters, right? Hopefully you believe that. You're watching this video, you must believe that. Now, look what's going on here. You can see that her pelvic floor has reached peak activation with her butt just a little teeny bit off the seat of the chair. So if maybe you're an older person and you don't feel steady or secure doing one of these standing postures, lunging or squatting, you can start in a chair, seated in a chair, comfortable. Hold on to the sides of the chair and just lift your butt an inch off the seat of the chair. Now, if you do that, you can pulse the pelvic floor from that nice, secure posture, just an inch off the seat of the chair, still holding on to the side, percussive breathing, small range of motion, voluntary Kegel, and if you can't do anything else, that's going to be enough to improve the performance of the pelvic floor, right? So all the 10 PfilAtes movements are modifiable, but we have trained thousands and thousands of people and have been able to find a movement for every one of them, and maybe this would be your movement. Maybe you'd like one of the other movements. And there seems to be a few movements that are most likely to give people the most benefit, right? Lunge, squat, hovering, bridging, cat into cow. We call those the essential PfilAtes movements. And so since we can't do a VESI session on every single person that's going to use PfilAtes, we use the movement selection worksheet, which takes advantage of the client's subjective experience to help choose their movements, the movements that they can do, that are not causing discomfort, that they like to do, and that give them a subjective sense of good, strong pelvic floor engagement. But we always suggest that they pick one of those 5 essential movements, right? At least one. 2 is fine. As they create their 2-movement program that they're going to practice 5 minutes in the morning and 5 minutes in the evening. Now, what else? This is a paper that was published a few years ago now that basically looked at 100 consecutive patients at the Center for Pelvic Floor Medicine that showed up complaining of bladder control problems, that embarked upon the PfilAtes method, and that had every one of them had a VESI session, and that allowed us to measure the strength of their Kegel exercise, but also the effect of each of the 10 PfilAtes movements on their pelvic floor. And when we used each of these 100 subjects as their own control, that is to say, we used their Kegel as their non-movement pelvic floor activity potential, and then compared the maximum pelvic floor engagement possible with the PfilAtes movement, we found that each of the 10 PfilAtes movements was statistically significantly better than the isolated Kegel. But we also found that for any given patient, one of the 10 PfilAtes movements might not be any better than their isolated Kegel. And so that's why it's so important to at least start by not doing all 10 movements. Just finding your best 2 movements is going to concentrate your effort in the most effective way. You know, I always say what we need is a accessible, affordable, efficient, and effective program. Well, part of the efficiency is making people better quickly, right? So they don't give up, so they don't say, forget it, I'm just gonna have an operation or take a prescription with side effects, right? Now, sometimes you need those things, but I think the vast majority of people with bladder control issues can avoid those things with a pretty simple solution, right? And so that is sort of the backstory of why we suggest, at first at least, just picking your 2 best movements. And then once you're better, feel free, go back, revisit the other 8 movements. Maybe think of them, wow, how is this showing up in my daily life? Oh, yeah, side-lying bent knee lift is kind of like getting out of the car. Huh. Oh, and then start moving differently all the time. That's what Joseph Pilates said. He said every movement begins with the core. First the core, then the movement. It's just a movement habit that you have to get used to. With a little bit of practice, you can do it, and you'll be glad you did. Now, finally, here is a summary of our clinical data that was gathered with the same cohort we used in that last abstract that I had on the screen, 100 consecutive patients. And what we did is we gave everybody 3-day bladder diaries before they started the PfilAtes program. We gave them symptom questionnaires to measure the degree of bother, of subjective bother they were experiencing before we implemented the PfilAtes method. And then we taught them the method, and we had them practice for 28 days. And then they came back, and we repeated the bladder diaries, we repeated the symptom questionnaires, and we also asked them, if the problem was a 10 before you started on this, what's the problem now, right? And basically asking, how much better are you? And the average response to that question was 50% better in 28 days of training. Now, we had a technique for measuring the force of a pelvic floor contraction. It's called manometry. And after 28 days of training, the manometry results were on average 62% improved. And that seems like a lot of improvement in muscle strength in just 28 days. And I think some of it is probably a training effect. They're just getting more coordinated at contracting their pelvic floor, but good on them, right? That's one of the key things that helps people get better. And so we saw a greater than expected improvement in pelvic floor strength. Now, from the bladder diaries, we saw a 64% reduction in the number of leaks that were occurring each day. And we saw a 20% reduction in the number of times our clients were emptying their bladders, the voiding frequency, right? That's one of the complaints of overactive bladder, having to go too often, having to go in a hurry. And so we saw a 20% reduction in that. Now, when we looked at the subjective bother, when we looked at the symptom questionnaires, and on this slide they're called UDI-6, IIQ-7, we saw a 43% reduction in bother and a 61% reduction, 63% reduction in bother in that same 28 days. So everything was moving in the right direction. That's kind of what you want to see, and why you don't just pick one metric to study the effect of an intervention, in this case PfilAtes, right? Because, you pick one metric, it's more likely that the results you're getting could have been random or accidental. But if you pick, as in, this case, 6 different metrics, and they're all moving in the direction you want them to, it gives you a lot more reassurance that you're actually measuring what you're measuring. And so this data now seems pretty stable. As we add more data, it doesn't seem to really change. And even the data we're collecting now from the senior centers that are using this as a purely fitness offering for their members, we're seeing the same results, essentially, in terms of bladder diary and symptom questionnaire, which really gives us confidence. Once the data becomes stable, adding more people doesn't change the data, then you can move on and start studying other things. So I'll just reinforce the importance of consistency. Now, this is not rocket science, right? I went to, made some effort to try and explain the neurophysiology, the backstory of exactly how pelvic floor exercise changes the autonomic nervous system, to hopefully help you persist during those first 28 days to benefit the way 80% of our clients do, right? 80% or at least 50% improved in 28 days of training. So 5 minutes twice a day. Bladder's a fitness issue, and being proactive is absolutely critical. Do you remember the 3 essential elements of pulsing? Small range of motion, percussive breathing, you know what that is? Just like that. Makes a sound, your mouth is wide open. Sounds and looks a little bit funny, but it gets the deep abdominal muscles firing, and you remember that helps the pelvic floor. So So percussive breathing, and then adding that voluntary pelvic floor contraction on top of the movement and all of this really amplifies the effect of the movement on bladder control by virtue of both getting the pelvic floor muscles stronger, but also regulating the autonomic nervous system. Wow, I hope that was interesting. You guys still with me? I hope so. Like and subscribe. I'll see you soon.